about concepts of localization in neurology, how neurologists think, and touch a little bit about dementia. I'd be happy to meet with you again and again and again to talk about other fields, for example, research in dementia and other concepts. So first, I want this to be interactive, so please feel free to answer. So how many doctors are there in America?
A lot.
You know, so I want you to know where we are and where we're going. So there's about 1 million doctors in America. I don't know how many nurses are there in America. You want to let me know? How many nurses are there?
Like 6 million.
6 million. Okay, it's an interesting ratio. How many neurologists are there in America? So think about it. How many, out of 100 neurologists, how many neurologists would there be?
100,000.
100,000? So 10 out of 100 neurologists, 1 out of 10 are, that's wishful thinking. So there's about 25,000 neurologists. So out of 100 doctors, 3 doctors are neurologists. Whether that's good or not, that's a matter of debate. So there's not enough doctors, there's not enough neurologists, there's not enough primary care. A neurology residency program is usually 3 years for those who are heard about it. We study for 3 years and then we do a fellowship. Most neurologists become specialists in a field, and then most neurologists stay in tertiary centers. So there's not enough, they subspecialize in a very particular field in neurology and stay where they are. That means that there's not a lot of neurologists in the periphery, in the rural settings. Here, how many neurologists are there in Maine? Only about 40, 50 neurologists. That's it. We're the largest group. So there's not enough neurologists. There's not enough general neurologists. There's not enough specialists and so forth. Another thing I just want to touch is a little bit about history of neurology. When did neurology start?
What?
The modern neurologist started in the 19th century. So if you had a stroke in 1820, what would you do? There were hospitals back then. There were no emergency rooms. You would go to the emergency room, or you would go to the hospital, be admitted, and basically a good chance you would die within 7 to 10 days. Not immediately. Because how do you treat dehydration in 1820? There's no IV access. There's no antibiotics. They had opioids and even marijuana, but they didn't have modern treatments. There's no tests. Doctors used to taste urine and stuff like that. So in that kind of setting, patients would come to hospitals and die usually within a week or two with a presentation, a paralysis, can't talk, and stuff like that. Now, pathology departments, these are departments in neurology, departments in hospitals, were very well established. Microscopy was highly developed in the 19th century. There were microscopes and there was staining, and there was big, huge pathology departments. They were sitting around, and they were waiting for autopsies, basically. So patients came in, and they died after 10, 14 days from dehydration. And there were thousands of specimens to check. So that's where, it's not so such a nice scene, but that's how neurologists were born, basically. The first neurologists were pathologists. The pathologists were hanging out. They saw these patients with syndromes coming in, a paralysis, a facial droop, so forth, and they connected between the presentation and the way, what they would find later on. And then Dr. Weber and Dr. Desjardins and Dr. Wallenberg, if you heard these names, a Wallenberg syndrome and so forth, these are pathologists that were able to connect between, that patient comes in with a paralysis there and a numbness there and a facial droop there. They're going to have necrotic tissue in the lateral medullary region, and they were right after thousands of repetitions. So that's how neurologists were born. Now they developed a neurological exam. They had 10 days to poke and probe the patients. Now for what? Good question. Back then it was just academic. Okay, so that's where we come from. In 1890, the spinal tap was developed. In 1910, with the advent of X-rays, the first emergency rooms. 1920, 1930, the first EEGs, EMGs. So now we can start localizing. So someone comes in with a paralysis, so where's the lesion? So this is the term. How neurologists think. Neurologists think, where's the lesion? They look at someone and ask them, where's the problem? They ask themselves, where's the problem, before they ask, what's the problem? That's the difference between neurologists and internists, for example. If you have a if you ever see around in the hospital, there'll be a presentation, and then the doctor will ask, will ask the residents, what do you think the problem is? What's your differential diagnosis? But not in neurology. When someone rounds with me, and there's a presentation, I ask, where would you localize the lesion? So neurologists think differently than internists. We also are regular doctors too, so after we ask, where's the lesion, we ask, what's the lesion? But you have to understand that all the doctors you're working with, that's how they're thinking. It's actually good that you understand this, that they're thinking, and because all these referrals and the paperwork and so forth that you're getting, the neurologist is combing through the possibilities in terms of where, before the what, okay? And EEGs and CAT scans and MRIs and tests and spinal taps were all developed in order to find where the lesion is, because the nervous system is so complicated. And when you have a weakness on one side, it could be so many different possibilities in terms of the where, before the what. Of course, what is a big issue too. Okay, so I just want you to understand that. That's what neurologists do. I think neurology is amazing. It's like being a detective. So that's one concept. So I just want you to introduce to you some of our stations. Like someone comes in, there's a presentation. So what am I thinking in my mind? What am I doing? Well, so I'm saying, where's the lesion? So what are the possibilities? So I like to demonstrate this. So in neurology, you can divide the nervous system into many different lists or possibilities. A lesion, a problem in neurology can be cortical. That means in the here it is. So you can draw with me or you don't have to. So if there's a brain, so the outermost parts of the brain are usually the cortex. So I'm looking at someone, so maybe a problem's in the cortex. A problem can be subcortical, in deeper structures of the brain. So now I'm going deeper in the brain. Now there's going to be two pockets of fluid called ventricles, if you've ever seen them. So we're talking about injuries here, deeper. So a weakness can come from the rim of the brain, the cortical lesion, a problem from subcortical lesion too. A lesion can come from the brain stem. Deeper still. Now I'm going to flip the brain around, okay? So now I'm going to flip the brain to look at you. Did you ever see Mars Attack? Right? So now it's looking at you. This is called a coronal section. This is an axial section. So I'm looking at the brain from above, and I'm looking at the brain from the front. You got it? Okay. So now, if this was the cortex and this was the subcortex, now there's a little structure called the brainstem deep inside behind your eyes. So an injury can be there. The other possibility is a spinal injury. This connects to a spine. An injury can be here. Then there's a nerve root problem. Now let's flip it back to this section, like in an axial plane. If I flip this back here, and this is small, this is like very little, but if I blow it up, so there's this structure in the middle, and an injury can be here, can be here, can be here, in the spine. Dr. Baratish knows this very well, and so does Dr. Busquet and other problems. And the picture of a patient can give me telltale signs of problems here, subcortical, or brainstem, or spinal. The next station is the nerve root. At some point, a nerve leaves this area and goes back like this. And this area, where the nerve exits the spinal cord, is called the nerve root. Injuries can be here, like Guillain-Barré and shingles and other things. A problem can be in the nerve. Oh, sorry. Problem can be in the plexus. Plexus is a... So these are, where's the lesion? A lot of these nerves, again, if you see there, they leave the spinal cord. So some of them, they network into a complicated pathway called the plexus. There's different plexuses along the way. But an injury can be here, like brachial plexitis and other injuries. Dr. Belden knows this very well. Problem can be in the nerve itself. After this network of plexus, there's individual nerves that go to their destination. A neuropathy. And a problem, and after that, it's a neuromuscular junction. At the end of the nerve, it connects to a muscle. And over here there could be a disease, like myasthenia. And the last station in this way of looking is the muscle. The muscle itself can be injured. So neurologists see some problem and they ask themselves, where's the problem? Before they ask, what's the problem? They ask, is it a cortical problem? Is it a subcortical problem? Is it a brainstem problem? Is it a spinal cord problem? Is it a nerve root problem? Is it a nerve problem, a plexus problem, nerve problem, neuromuscular problem, and muscle problem? And this is one way of looking at it. I'm trying to simplify, but that's what we're doing in our head. So it's cool. Now, let's be more professional, right? Because you're encountering these professional terms all the time. If a problem is in the cortex of the subcortex, that's called a, you heard it all, encephalopathy. You hear this word all the time. When a neurologist says encephalopathy, they're basically saying that whatever is causing that problem, it's originating in the cortex or the subcortex. That means that the problem is either irritating the rim of the brain or deep inside this white matter area. Got it? Okay. If a problem's involving the brainstem, what would that be called? A bulbar problem. You would hear that, right? Bulbar problem. Bulbar problem means that the problem is originating in the brain stem. Parkinson's, other syndromes, and so forth. A problem in the spine, do you know what that's called? It's just a cooler way of saying it. A myelopathy. Did you ever hear about myelopathy? Doctor is suspicious of a myelopathy. What they're saying is that the problem is probably originating in the spine. Problem in the nerve root is called a radiculopathy. You heard that before? That means that whatever is causing the weakness or the numbness or the pain or the whatever is originating in this area. Problem in the plexus, come on, it's called a
Flexor.
ooh, I'm very impressed. Problem in the nerve is called a I can't believe it. Problem in the neuromuscular junction is called a, that's a trick question, there's no name for that. And problem in the muscle is called a myopathy. So you'll hear two neurologists going like this, this person had a car accident, or I like to call it a snowmobile accident, right? Any snowmobile master here? No?
No.
So,
No.
okay. People ride on snowmobiles with helmets.